Great. Okay, thank you very much. So actually, the next is, it's a great honor to introduce Dr. Indranee Rajapreyar, because first of all, she was my previous fellow, so I'm very proud. And second, she's now the director of MCS at Jefferson Hospital, and she's going to speak with us about a very challenging and very relevant topic, is the kinetic of HFpEF shock and how to manage HFpEF shock. So Indranee.
Thank you, Nair, and thank you, Marwan and Kyle. Dr. Carr, I'm happy to be back in Houston. So I'm going to try to do my best to, make justice to this talk. I have no disclosures and no data to support my discussion. So HFpEF, we're all familiar with this syndrome. It's basically increasing in prevalence, and the HFpEF cohort includes patients, a heterogeneous group of patients with symptoms and signs of heart failure. They have evidence of elevated left or bisided filling pressures with a normal LV systolic function. So the hallmarks of shock apply both to HFpEF and HFrEF. They have low cardiac output and plus-minus congestive symptoms, and defined by clinical and hemodynamic criteria. It could be physical exam or hemodynamic criteria. So what do we know about epidemiology and shock, about shock in HFpEF? No data, short answer. Most of these AMI shock trials have focused on acute myocardial infarction only because it's a homogeneous cohort. HFpEF cohort has a lot of heterogeneity. And even the cardiogenic shock working group has included patients, that has made an effort to include patients with chronic heart failure. The median ejection fraction is around 20%. So this is, again, another study that showed that patients presenting to the cardiac intensive care unit, 2/3 of patients presented with cardiogenic shock, only 12% of that cohort had EF of 50%. So why possible explanations? Shock in HFpEF, not well-known entity, different in idiopathogenesis, natural histories, and treatments may represent a challenge in reporting outcomes. And recognition of shock may be challenging due to chronic low output state in these patients, and these patients may have some degree of end organ dysfunction. So this is just my mental checklist, how I go through when I see a patient in any shock, but I think echocardiogram will give you a clue as to which kind of shock you're dealing with, HFpEF or HFrEF. It's important to phenotype these patients first. The garden variety HFpEF, the patients who are older, obese patients with comorbidities, and cardiogenic shock in this cohort of patients is less frequent unless you have restrictive cardiomyopathy or right ventricular failure, especially if these patients have group 2 PH that progresses. You could have RV failure. So majority of these patients need RV support. So the other disorders that are mimickers that I would call, they have primary myocardial involvement, the restrictive and the hypertrophic cardiomyopathy. We all know the amyloid, the inherited amyloid, or the malignancy, AL amyloidosis, hypertrophic cardiomyopathy, and then you have the myocarditis, coronary allograft vasculopathy, and also in some TAVR patients when you have suicide ventricles. So this is the cohort that I'm going to talk about. The valvular and pericardial diseases I don't consider them belonging to this cohort. So we all know the pathophysiology of shock. All roads lead to myocardial dysfunction and death. So the basic principles that I follow for shock management and HFpEF is there should be a high index of suspicion because these patients have chronic low cardiac output state and some degree of end organ dysfunction. I think a hemodynamic assessment, an invasive hemodynamic assessment, will definitely give you a clue as to how you would approach these patients. These patients are highly preload dependent. You need a higher CVP to maintain cardiac output. I've seen patients going into shock because of excessive diuresis. These patients do not tolerate atrial arrhythmias, as one of my colleagues would say. This is the beginning of the end for some of these patients who present with amyloid. And they are sort of equivalent. I consider them equivalent of ventricular arrhythmias and HFrEF. And bradyarrhythmia is also poorly tolerated because of poor limited stroke volume. These patients need higher stroke volume. And then these patients have biventricular predominant shock. So that becomes the basis when you consider mechanical support. And this is just the assessment, echo, and lab data, and hemodynamic assessment. We've gone at length during this session. And some of the triggers that I look for: arrhythmias, recent introduction of AV nodal blocking agents, infection, PE, anemia. These all could be triggers and reversible causes of shock in these patients. As you're thinking about supporting these patients, I think it's essential to rule these out. This is just a summary slide about how we approach a patient at any shock, but in HFpEF, severity of shock, rule out other causes of shock, multi-organ support, mechanical ventilation, renal replacement therapy, if these patients are in arrhythmias, cardioversion, and pacing, if possible, these patients have implantable devices. I just dotted arrow to the ionopressors because I don't believe in having inotropes in patients with HFpEF because you're just not going to do any justice. In some cases where you could, I believe in using dobutamine for some lucitropy, or if you want to increase the chronotropic support for these patients if they're bradycardic, it may help. And then the hypertrophic cardiomyopathy patients who have shock, the obstructive component, you treat them with esmolol or phenylephrine or a combination of both. My approach is to escalate these patients to temporary mechanical support and then simultaneously deciding whether these patients are recoverable or advanced therapies. So the kind of support, again, unfortunately, there's no data to support which device is better, but biatrial, as I said, these patients present with biventricular predominant shock. They have smaller cavity size, restrictive physiology, so I favor biatrial unloading. In my previous experience at UAB, we used the LAVA cannula, which is, again, a multi-stage cannula, which would do biatrial unloading. Works well for these patients. Again, with the caveat, you're stabilizing these patients. The prognosis depends on the long-term therapy, what you have planned for these patients, reversal of end organ dysfunction, reversal of frailty, and optimizing their nutritional status. So long-term strategy, either transplant or TAH, those are the two options, and then you could have the surgical BIVAD centromag as an intermediary device until if you have to wait longer to bridge these patients. So that's it.
So this is actually a very, David, maybe we'll start with you. Biatrial approach, that's one of the big things that actually Indranee said that we didn't hear it today. We spoke a lot about VA ECMO. We spoke a lot about Impella. We spoke a little bit, when Dr. Carr is here, that definitely someone that teaches us a lot about biatrial and single atrial, even unloading. This is also your approach to HFpEF shock?
So it's very interesting. I've done tandem hearts for this kind of problem. Not actually used the LAVA catheters that weren't around when I was doing those. Well, the other question I would have for you though is if you, for example, have somebody's restrictive or severe ischemic disease, such as a transplant with severe vasculopathy, have you used an intra-aortic balloon pump for this?
Yes, I have, but it all depends. If they have RV dysfunction, then the balloon pump really doesn't help.
Yeah.
So that's a struggle. With just using the balloon pump, we've had to escalate these patients to some other form of support.
Yeah, just anecdotally, sometimes patients with restrictive type of features, or particularly ones in transplant, even before the 2018 allocation, where you still waited months and months, some of them did very, very well with placement of a balloon as a way of supporting people with completely normal function. And the LAVA is very interesting. If you do LAVA ECMO, is this a special design catheter or just a regular right-sided, just regular catheter with multiple holes that you put across the septum?
I think it's a multi-stage cannula from Medtronic that can unload both.
Yeah, no, that's a very challenging phenotype, but I think the two cohorts that come out of this is that amyloid and then graft failure. I find it particularly challenging, and I'd like to hear your thoughts in the panel, when you have graft failure early after transplant, and if you close the chest, you come out of the OR, and you then end up on a peripheral ECMO. Unloading these LVs is particularly challenging. For the most part, we've gotten away with balloon pumps, but there are a few patients where your LV doesn't unload, and then you're having this small LV, you put in an Impella, and it's a disaster. So my question is, in these situations, would you recommend just going back to the OR, opening up the chest and putting in an LV unloading, or put a tandem, or what's your approach?
I think a tandem. I mean, these patients, again, the ones that I've seen, PGDs are biventricular support. So I would favor the lava cannula for biatrial unloading, but you could get away with just LA unloading tandem and supporting the right side with inotropes. But it all depends on the degree of shock on the right side too.
I have to say, in the beginning when we start seeing more PGD, we use Centromac Bival, but immediately we understand the best way is to do something very, very short acting, because you know that in 24 hours, 48 hours, hopefully and probably, you're going to be okay. We moved to peripheral ECMO and we found it to be very, very easy to do and something that most of the patient will get out. Of course, the main question that you need to ask yourself that is outside of the scope of this is what was the cause of the PGD. And I think if it's something that is preservation injury that is so significant, maybe sometimes this will not be enough. But I'm exactly like Indranee, the minimal way, peripheral ECMO in those patients. But Indranee, there was a couple of more things that you said, that this is the preparation for an exit strategy. So maybe we can start.
So two things were discussed, specifically the restrictive cardiomyopathy and the transplant, but the phenotype diastolic heart failure with group 2 pulmonary hypertension presenting as primary RV/RA dilatation is the most difficult entity to treat. So nobody commented on that, and that there is no treatment strategy for these people because they don't have blood pressure issues by the time they come to you. They have low blood pressures, primarily they're volume overloaded. You cannot unload them because of the blood pressure. They end up going on dialysis and ultimately they die. So
I didn't intentionally discuss that topic because that's the frustrating part. You can't use pulmonary vasodilators in this cohort, and they are not candidates for any advanced options. It's just palliation once they end up. You can try inotropes, but that's not going to fix the problem, unfortunately.
We often will use pressors to raise the blood pressure to perfuse the RV, and just aggressive diuresis up until dialysis, and then they die.
So
They die.
Yeah, I mean, we end up at the same spot.
Yeah. I think this shock symposium we have talked about a lot, but there's a lot of data of midodrine usage and early mortality. So we have to be very mindful of the fact that people convert vasoconstrictors, which are IV, to oral midodrine and expect that they're going to do well, but long term they don't do well. There's very clear-cut data from renal literature. People who have used midodrine for dialysis, they don't live well.
Yeah, no, I agree.
I'm curious who has the expectation that they do well.
Yeah, so Ajit, maybe last comment from Ajit?
No, I think to your point that the pulmonary vascular remodeling in these patients, the Mayo had a nice, pathologic study looking at vascular remodeling in these patients for group 2 and group 3, and they're, that's probably, we see this in HOCM too, where the Marins had described those patients who have significant pulmonary hypertension. So I was wondering if you think a lot of these patients have sudden cardiac death, about 20%,
yes.
and is it they're phenotyped incorrectly? Is it a pulmonary vascular problem? Or of course, you have a rhythmic problem, those patients who have CAD, but what do you think that mechanism is? Or is it a ventricular arterial coupling problem, and hence the IABP works out?
I think it's so difficult to say because these patients are not even phenotyped within the HFpEF cohort. If you look at the study, I think the mode of I don't remember, it was published in JACC, where the mode of death was sudden cardiac death, but they're not able to characterize how they died. It may be if they have PH and RV failure, that's the mode of death. I think it's important to characterize and phenotype these patients ahead of time. It's so difficult to say one would be, sudden death is due to an electrical problem or worsening RV failure or existing CAD. These patients have pre-existing CAD and scar-mediated death from VFib. So it's so difficult to really, pin the sudden cardiac death in this cohort of patients. That's what I think.
Indranee, thank you so much.